What's going on, everybody? It's Alex here from Aleks Physio. So today we're going to be talking about meniscal tears. Specifically, we're going to be looking at some of the anatomy of the meniscus. We're going to be looking at what are some signs and symptoms that we look for if we think that we may have had a meniscal tear. I'm going to look at some of the research associated with the meniscal tears, some of the treatment options related to meniscal tears. But before we do all that, if you haven't already, please subscribe to my channel. It really helps me to reach more individuals with my content. I have almost 200 videos that I've posted on various exercises, conditions, diagnoses, and just different chats about various conditions and kind of how to treat them. So, before we chat about meniscal tears, what is the meniscus? And there are two menisci, plural for meniscus, in our knee. And these menisci sit in between our shin bone and our thigh bone. They are a type of cartilage structure, and we have our medial meniscus, which is on the inside of the knee, and then we have our lateral meniscus, which is on the outside of the knee. Out of the two, the more likely to be injured is the medial meniscus, and it just has to do more with where it attaches with respect to other structures around the knee and just some of the forces that are involved in some of the typical mechanisms of the injury, not to go too far into the anatomy. So if you've had a meniscal tear, or if you think that you've had a meniscal tear, what are you looking for? What are some of those signs and symptoms? So you're looking for an event, an acute event for the acute meniscal tears. And the most common way to injure your meniscus is a twisting motion. So if you're pivoting on the leg, if you're twisting and changing directions, if you're playing a sport, you usually may hear a pop or an audible sensation, into which you would have immediate pain, swelling, and a lot of clicking or blocking of the knee, depending on the type of tear that you've had. The other side of it is there are meniscal tears that are more degenerative in nature. So this is for individuals who are a little bit older, who have just been through more time walking, running, jumping, just over the years. All of that kind of adds up onto our knees, and then we may not have a specific moment where we feel like something has gone wrong, but it's something that has progressed over time. So if you're having some knee pain and you had to go get an MRI, you may find a degenerative meniscal tear. So why do I mention the two? There is a difference between the two in terms of how they're treated, because generally some individuals may have degenerative meniscal tears and not have any symptoms. And some individuals who have the acute tears, they have a specific moment where they felt it, they have pain, and if they're a high-level athlete, that may be treated differently in terms of potentially having a surgery versus the prognosis or the likelihood of a full recovery for a degenerative tear in somebody who's older, usually older than 40, might be more on just treating it conservatively. How do we know if we've actually torn our meniscus? So you look for some of those signs and symptoms. You see a physiotherapist. There are a lot of clinical tests that can be done to increase the likelihood or the confidence that it is a meniscal tear. There are some tests such as Thessaly's, Apley's, compression and distraction tests, and then there's another test called the McMurray's test. So these are all tests that are meant to kind of bias the menisci into positions that are meant to irritate the meniscus a little bit more. Moving your knee into hyperextension and hyper or end range flexion, those can irritate some of those symptoms of your knee. And also just palpating or feeling around kind of the joint line of the knee can sometimes help with regards to diagnosing a meniscal tear. But the gold standard for a meniscal tear diagnosis is a MRI. So contrary to popular belief, you cannot diagnose a meniscal tear from an x-ray. It has to be done via an MRI, just because the MRI can see more of the soft tissue structures. So when you have a meniscal tear, sometimes there may be associated injuries with that tear. Usually if somebody tears their ACL, there is likely to be associated meniscal and MCL involvement. So your MCL is the ligament on the inside of the knee that provides some of that knee stability. This is called the terrible triad. So these three injuries can happen in succession. Meniscal tears can happen in isolation on their own though, so that's important to know. And there are different types of meniscal tears, and meniscal tear types play a role in determining what is the best treatment available for me, whether that be a surgery or whether that be conservative care, aka physiotherapy and rehab. Here's a photo that just kind of goes over some of the different kinds of meniscal tears, but we have longitudinal tears, we have flap tears, we have radial tears, and depending on where these tears occur, that will play a role in determining what the likelihood of this meniscal tear is to recover. So you have three zones. You have your red zone, which is the outside of the meniscus. You have the red-white zone, which is in the middle third of the meniscus, and then you have the white zone, which is on the inner third of the meniscus. These names are associated with the amount of blood supply. So if you injure your meniscus and it happened on the outside of your menisci, then the blood supply is actually higher, and as a result, the likelihood of you to recover is higher because our bodies and our tissues need blood flow to deliver oxygen, nutrients, and help with some of the healing. So if it has good supply, it has a higher prognosis. In the middle, there's a little bit less blood supply, but there isn't absolutely any blood supply. So prognosis is more difficult or longer, but it may still recover. And then the white zone is usually not going to recover at all because there's no blood supply in that area. So this is really important to know, because if you do a clinical test with your physio, you might not know, or you won't know, the kind of tear that actually happened. So that's where an MRI is useful in determining, especially if you want to go potentially the surgical route. There is some research that compares surgery versus conservative care, and again, depending on just the different kind of injury that you had and where the injury occurred, that would play a role in determining if you're going to go rehab or surgery route. There is a lot of research that supports that rehab tends to fare better than surgery, but again, there's a lot of factors that you have to consider just with regards to all of the things that I mentioned. If you were to go the surgical route, a lot of surgeons will say start with physio first, usually for the first 3 to 6 months. See how it is, see if you can get any improvement in your strength, your pain levels, your range of motion, the swelling, and then from there we can determine whether or not we want to do the surgery. Very rarely will they go directly into the surgery unless maybe you're a high-level athlete and you need to get back to sport as soon as possible, and the individual is a very good candidate in terms of the type of tear that happened and where the tear occurred. So that's one thing to be mindful of. And then physio would kind of involve strength training of your knee, of your hip, your core muscles, improvement of your range of motion, because a lot of times you'll be limited in your bending and your straightening of your knee, in addition to different modalities just to help with some of the swelling and help with some of the pain, and getting you on an aerobic program just to get you moving a little bit more. If you go the surgery route, then there are a couple different surgeries that you can have. There's a meniscectomy, which is basically where they take the entire meniscus out. There's a partial meniscectomy, which is where they take part of the meniscus out and the part that is torn. And then they can also just do a diagnostic arthroscopy, or just an arthroscopy in and of itself. And that's just where they insert little cameras. They make a small incision in your knee, and then they insert little cameras, and then they just have a look at what's going on within your knee. And if there is any debris or anything that may be causing some of that locking or some of that clicking and some of that pain, then they can just debride that, or they can just get rid of some of that is in your knee, and that may help with some of the symptoms. It's important that you just look at both options though, because it all just depends on the individual and the individual's goals. I've seen individuals who have had meniscal tears and treated them very well without surgery. So they're obviously, and I'm biased of course because I'm a physiotherapist, but we always try to push the conservative route first, and hopefully even if you don't get to that level of recovery that you may have gotten to with surgery, then if you just did surgery right away, by you participating in a rehab program, you're still optimizing your prognosis after the surgery to get better, versus if you kind of just waited until the surgery, depending on when the surgeon was available or how long it took for you to actually get in the OR. So it's just important to know that you do have options with regards to how you want to manage the injury. The other thing to be mindful of from a symptom perspective is squatting. So generally the loads when you squat are higher when you do have a meniscal tear at about 90 degrees of knee bend. So the further you squat, the lower or the more load that is going to your meniscus, and as a result that's likely to provoke a little bit of pain. So generally if you were to have a surgery, a lot of times some of the surgeons will put some restrictions with regards to the amount of squatting that you're doing, especially early on, because you don't want to compromise the healing of that surgery because everything is still inflamed and the tissue is still kind of recovering from that surgery. So just some things to be mindful of. So that's it. So we chatted about the menisci, we chatted about some of the anatomy associated with it, we chatted about the different zones and the role that blood flow and blood supply has in recovery from these meniscal tears. We talked about surgery versus conservative care and kind of what the pros and cons are of each. And we talked about some of the signs and symptoms, things that you look for if you think that you may have had a meniscal injury. And also we looked at some of the mechanism of injury and how a meniscal tear can manifest itself. And then we also compared acute tears versus degenerative tears. And it is important to note that with degenerative tears, some people can have degenerative tears on MRI and have no pain at all. So just being mindful that MRI plays an important role, but it's one piece of the puzzle in somebody's overall recovery and in somebody's overall prognosis for their injury. I hope you found this information valuable. Hope you learned a thing or two about meniscal tears. If you have any comments or questions, please leave them down below. And if you can like this video and subscribe to my channel, that'd be super appreciative, or share it with a friend or a family member, that'd be great. Thanks so much for listening, and stay tuned for the next video.